Welcome, everyone, to Howling Coyote. And I'm happy tonight to have Michelle Loy, who's an integrative medicine physician at Weill Cornell Medical Center in New York City on the Upper East Side. And it sounds like an exciting facility that they've created. And I'm sure she'll tell us a little bit about that as well. But I came across Michelle through the Andrew Weil Integrative Medicine Program and some of her writing on narrative medicine and thinking. And I thought it would be fun for us to have a conversation. So, Michelle, do you want to say anything more about yourself or where you work or your affiliations or?
Sure. Thank you so much for having me on this podcast. So I am an integrated medicine physician at Weill Cornell Medicine, you're Presbyterian. At our center, we have several integrated medicine physicians. We have acupuncturists. We have a dietitian, psychologist, massage therapist, osteopathic services. So most of my work, well, half of my work is one-on-one consultations on related to integrative medicine for all ages, from children to adults. But I also spend a part of my time running a number of shared medical appointments or group medical visits. And one particular area that one of my colleagues and I piloted was a narrative medicine group visit. So that I think is a very unique offering, especially at an academic medical center. And the feedback from our patients has been that they really appreciate this particular group visit. So maybe if we have time later on, we can speak more about that.
Sure. I'd love to hear what you do in the group and how it flows and things like that. That would be really interesting. So, tell us a little bit about your background, where you grew up and went to medical school and went to undergraduate and all those good things. I know you have a child who plays a brass instrument.
Yes, she's one of my 5 children. Yeah. I just had to ask her to take a little break so we could record without any background interruption. Yeah, so well, I'm of Chinese origin, but I was born in the US. And let's see, I grew up in New York. And I went to college in Boston, and then I went to medical school at Weill Cornell, actually. And then I stayed for my pediatric residency at Cornell as well. And after some time in pediatric general practice, maybe about 15 years into that, I decided to go back and do fellowship in integrative medicine. This was after, witnessing in my practice a lot of the chronic conditions that our patients faced. This was after raising 5 children, and this was after facing a life-threatening health crisis in my family. So at that time, after passing through all of that, I felt like it was time to pursue what I really wanted to do. And so I decided to do integrative medicine fellowship sort of midlife. And I did that at Stanford Hospital, the Columbia program. And at the same time, I did the Andrew Weil program, which is how I learned about you and all your amazing work. And I heard you speak at the alumni conference. And by the way, I listened to your podcast recording that you gave prior to the actual
Oh, yes.
yeah. So I was there for in person. Then I went back and I listened to all your podcasts, as many as I could, and I heard that. And then after that, I think I listened to that same podcast at least 2 or 3 times because I just think that's a phenomenal. It was on storytelling, narrative medicine, neuroscience. Yeah, so that's how I got, found out about all your work. And then I went back and looked at all of your research, especially the one on, there's just so many, but anyway. The one on the chronic pain group with the I think they were residents. That one really stuck out to me. And anyway, so I did my fellowship, so my in-person integrated medicine fellowship at Stanford, and then concurrently I did the Andrew Weil Integrated Medicine Fellowship, and I got my medical acupuncture board certification and my lifestyle medicine board certification and integrated medicine board certification. And then in the last 3 years, I came back to Cornell as faculty and practice 100% of my time is in clinical care and integrative medicine. And as I said, I've started a number of group visits, narrative medicine being one of them. I also spend some, a portion of my time in medical education. I give the first year medical student lecture every year on integrative medicine and coordinate a half-day experiential where they experience acupuncture and qigong and all of that. And I always try, I have a very short lecture. It's only about 30 to 45 minutes, but I always try to include a little bit of narrative medicine, even just a slide or two, because that's my only chance to reach the entire medical school class. And then subsequently, when people are interested, they'll join. And I have had several medical students, many residents, and even definitely fellows, but colleagues, not only at our institution, but many from other institutions who've maybe come to a talk on narrative medicine that have asked to shadow and join us in these group medical visits. Some are physicians, some are psychologists, one was a chaplain. So that's been good to see the interest.
Yeah, that is wonderful. One of the things I wonder about is, I mean, because before we started the podcast, we were talking about how I was part of an effort at Beth Israel to create an integrated medicine center that ultimately didn't make enough money to please the people in charge and was closed. And so I wondered how you guys managed the financing of this sort of clinic.
Yeah, so I think that's one of the very unique aspects of where we are, because we're part of a very large academic hospital center. And, many of our referrals are from our colleagues from various fields. Department. Okay, so just for me, I get referrals from Department of Medicine, a lot of oncology referrals. I have a big oncology practice. I get referrals from pediatric, we get from pain management, from OBGYN, from, almost all the different areas, you name it. And our patient population, we accept insurance. So it's maybe probably partially, some of them are Medicare and some of them are conventional, insurance. So it's all sustained by insurance. And particularly, I think these group visits are very special because they also are covered by insurance. They're shared medical appointments. And so in that way, we can provide these, experiences for our patients in a sustainable way.
That's wonderful. We, at Beth Israel, we also accepted insurance, but I wonder if our overhead wasn't too high, perhaps. It's hard to know, because I wasn't part of the leadership team. And they kept their cards close at hand. And so I don't really know why we failed financially, but I suppose Beth Israel failed financially too, because they're no more. They don't exist anymore. So it's the way it goes. But no, that sounds exciting. And so so how did you discover narrative medicine?
That is a very good question. So as a child, I loved to read. My favorite place was to go to the library. It still is. I think I'm one of the few people that actually, use the library for books, but then, as a place to charge some device. And I even said one of the things I wanted to be was either a librarian. I thought that if you were a librarian, you could read all day, or a flower arranger or a cake decorator. I ended up not doing any of those. But I did grow up loving to read, especially about medical stories and stories of triumph. And I remember reading about people with cerebral palsy and cystic fibrosis, and I was just fascinated by these kinds of stories. But then as I entered medical training, you get busy and you end up having no time to do any of this kind of reading. And so two things. One was when I mentioned this family medical crisis, through that I was introduced to, I don't know what they called it, but it was some kind of expressive writing or journaling kind of session at a retreat, which I remember was difficult to do. I had a really hard time doing it. And I didn't think I would ever want to do it again, or that it was that enjoyable. It was very difficult to do, but the process of doing it was, I could tell it was very impactful. And then, so that I just left it at that, didn't, but through that time, I also rediscovered reading again for pleasure, but also I think to rediscover the joys of being in medicine and all of that. And so I started reading, finding books like, well, these are the books that I recommend to my students now, like, but like things like Paul Kalinathi's When Breath Becomes Air, a whole bunch of these types of books, some other ones. Anyway, I have a whole list of these very sort of impactful books that are the reason why many of us go into medicine. So then I think through that, then what happened? Somehow I found out about the narrative medicine workshop at Columbia that Rita Sharon runs. And I think what happened was then we had she's a retired internist, but did pastoral care work at our hospital, like a kind of a extra training. And so she joined our practice kind of part-time. And we both realized we had an interest in narrative medicine, and we had a thought of bringing this to our patients. So then we took that workshop together, and that's basically how I got into this field. We started just piloting this group visit. I had already piloted a number of other group visits, especially a very successful one was in oncology, living with and after cancer, and that was a very popular group visit. And so I thought, well, maybe we could start with that population first. And we just had a one session out of the 7 sessions that I had. You know, one's on food as medicine, one's on acupuncture, one is on you know, mindful, joyful movement like yoga, qigong, you know, another one on herbs, botanical supplements. These were topics that patients often asked about. And then we decided to try one on just one session on narrative medicine, describing the benefits, the science behind it, and giving them a short experiential. And after doing a few rounds of that, people really liked it. And so we ended up deciding to do a separate narrative medicine series every other week, which we opened to all medical conditions, not just oncology. And that's what we've been doing for now, I'd say at least a year or two. And every other week, we have a 1-hour session. And it's been, I say that it's one of my most favorite parts of the week. Because it is it's something you don't really find in medicine. It's so important in healing, but it's not something that's really, you know, it's not common to find this in medicine. And so
It's amazing how we've divested medicine of humanity. And I don't know why we did that. Do you have any idea? I mean, what was that about?
I don't know. I don't know. You know, all these students come in. I mean, I was like that too, you know, just right. You go through this, you go with the big passion and all that. And then as you go through the training process, it's just, I think the humanity gets wrung out, you
It's
know?
distracted. Right. It because and I think about, you know, I've read that after 6 hours you stop learning. And so I thought, why don't we just have, you know, interns work for 6 hours and then read books, you know, read novels and, you know,
That'd be great.
paint.
Yes, exactly. Exactly.
It it's there was another interesting statistic that I read and from anthropologists who said that in hunter-gatherer societies, in general, people worked about 16 to 19 hours a week and spent the rest of the time singing and dancing and doing ceremonies and, you know, having fun, hanging out.
Yeah.
And I thought, it must be, well, I wanted to blame it on capitalism, but communism is equally bad. So there's something about modernity, however you define it,
Mhm.
that that wants people, that wants to take everything from people.
Mhm.
Almost, well, and of course the ultimate example of that was slavery, where you know people were actually owned. But but I think we would all be so much healthier and such better doctors if we had time to play music and paint and read and write and
Absolutely.
yeah.
And that's what I tell these first year medical students. It's usually maybe 3 months into their training. And I share with them the data on burnout and the importance for self-care. And, you know, and that's why we like them to experience the acupuncture and the qigong and all that early on in their training, so that first of all, they can use it for their own well-being, so they can be better providers, but also so that they can learn about it and offer it to their patients, you know, as but I think it's so important to give them that experience early on, And I tell them, it's sad, but I'll tell them, you know, some of us are involved with the medical school admissions and all of that, and we see all these, applications, these amazing, students and all of their qualities, and they're hardworking and they're empathetic and all of that. But I often will, caution these trainees that they have to take care of themselves. And this, I think narrative medicine is a really good way to prevent burnout. I really do, because it restores the empathy. It allows the trainees to process the grief and all that it goes through as you're taking care of patients, right? And allows for sustainability and longevity in the practice. But I always feel kind of bad showing them the data on burnout when they're just starting medical school. But the reality is, we see them go through first year, second year, third year, fourth year, and then as interns and residents, right? And then I see them 10 years out, 20 years out, my colleagues, burnout is there. And so we really need to take care of, even recently, one of my colleagues, we had a team, we have this kind of every couple times a month, people will give a talk, and the psychologist talked about dealing with dying and patients in our practice, for example, what it's like, dealing with loss. And, even in integrated medicine, where we're so aware of this, I realize that we often just, as clinicians, we aren't given the space to deal with this, with our emotions and our reactions to different, throughout patient care, some of the emotional repercussions. And I think that narrative medicine is a wonderful way. It's not only beneficial for patients, but it's really important for clinicians.
Yeah. Yeah. And so maybe this would be a good time to tell us about some of the things you do in the narrative medicine group.
So in the narrative medicine group, we usually start with centering time or meditation. The other provider will often do that. So she mostly leads it, and I'm there to listen and monitor the chat and take notes and also moderate to some extent. So we start off with that. We usually will ask patients to, it's optional, share something that they noticed sensorially that day, maybe something they heard or noticed or smelled or taste. And then usually we'll provide a prompt, some kind of prompt. It might be like a literary, like a poem, or some music or some artwork. And then and there are different topics, a lot of different topics that we will address. And then we'll give time to write. And then the best part is when we come back and people will share. And our patients have many, many different diagnoses. It's very interesting. It's a mixed diagnosis group. We have chronic pain, we have cancer, we have grief, we have PTSD. I mean, we have, all sorts of diagnoses, a lot of anxiety, depression, insomnia, but it's really not so much about what medical condition they have or symptoms. It's really just a community, or a wonderful community. And it's a very diverse group. And patients have said things like they love, and it's over Zoom, right? And so you would think it's, how can you connect over Zoom? But patients will say like, it's just amazing. Like, it doesn't matter what background, what, political leanings, like none of that matters. Ethnicity, none of that matters. What any kind of background, they feel such a connection with each other. And, I know a lot of these patients, some of them are mine, personally aware, or in the practice. And there are some aspects of healing that, you know, it's not a medicine. It might not even be acupuncture, but there's something about being in that narrative medicine group that heals them. And it's amazing. I mean, I know because you experience it, but I
Right.
mean, I've had patients with schizoaffective disorder, like, and or just all kinds of diagnoses. And yet, because they feel listened and heard, and they're able to share in the group, there's some kind of healing there. I'm continually amazed by that. And I used to think that I had to have all the answers for every topic, and it was a lot of pressure. I was really nervous about it. And then I realized that's not what it is. It's the group together. And it's like you mentioned in your, I've heard you speak, where it's a circle where everyone is equal. And we just, if we're willing to be vulnerable, to share and to listen. And some of my patients don't like to share, and that's totally fine. We tell them, if you're just sitting there and offering your generous listening, that is just as important to the group. So, and each group is always so different. We never know what's going to come out of it. Of course, we have 2 medical practitioners there to, be there to support. But yeah, it's really amazing.
Yeah, it's so exciting. It reminds me. So in the year 2000, um, I started a circle at Beth Israel, and it was it was we didn't call it a narrative medicine group because we didn't have that terminology then. We called it a healing circle, and it was for people to come who had something to contribute to healing and who needed healing. And we met every week for 2 hours at 5 p.m. so that people could come after work, 5 to 7. And and it went on for the duration of the time I was at Beth Israel. And the really amazing thing is that they're still meeting. Yes, they still they're still meeting. It still exists. Isn't that amazing? It's the power of circle. Like I left. I mean, you know,
I had no idea. That's amazing.
it is amazing. Yeah, 23.5 years later, they're still meeting. And they
Wow.
kept meeting during COVID on Zoom.
Wow.
Yeah, and people have, they've added people and lost people. And
Yeah.
I think there's probably 4 or 5 core people who've been there the whole 23 years. But it just shows you the power of this sort of thing. And certainly part of it, in 2000 we were a little we I don't know, we knew about the power of storytelling, but we didn't call it narrative medicine yet. I
Mhm.
think it took Rita Sharon to to coin that phrase.
Mhm.
Although in New Zealand and Australia, they called it discursive practices. And that was going on well before 2000. So, and, translated into American narrative medicine.
Yeah.
Yeah. So that's pretty exciting. And, and so how are you applying this? Tell us more about how you're applying this to medical education.
Um, I mentioned the medical school lecture. I actually have several colleagues at our institution that are really doing a lot of narrative medicine. Um, yeah. So one of them is in the Department of Emergency Medicine, and she's incorporated into well, she herself is an amazing writer, so she's published a number of narrative pieces in JAMA, and this is Rachel Kowalski. Um, and she also has included it in, she actually has developed like a narrative medicine track within emergency medicine. And also even they have it's amazing, protective airway course where they actually um, um, interview different practitioners talking about their experience with difficult airways. And she's included that in as well. She also is part of this. We have a LEAPS, longitudinal educational program for the medical students. And so for every topic, they will include some kind of narrative piece. So like I know when they're introducing I think it was, yeah, anyway, the integrated medicine piece, they're trying to look for like a Taoist poem to kind of introduce it. So they weave it into the medical education that way. And then I have another colleague who actually leads tours at the Met. I think she's in the Department of Geriatrics. She has training in art, and so leads these, I guess, museum tours for faculty and trainees, using art for, clinician self-care. So these are some ways that I can think of that narrative medicine has been used in education.
Yeah. And it seems like there's sort of maybe three streams. There's the stream that Rita Sharon works, which is for the benefit of the doctor. And then there's the stream of interacting with art in some way, which is good for everyone. And then there's the therapeutic stream of how do you use stories for the benefit of people to feel better, to get well. Uh, and 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 some people are working in all three streams, and some people are working in only one or two. And it seems like that you're involved in all of those to some degree. That
Yeah,
yeah,
I mean, I feel like I use it every day in my clinical care because that's my main work. But I think of, whenever I have, so it's rare to have integrative medicine, access to physicians, especially covered by insurance. So I get a lot of really complicated referrals from all over. People find us. And so I actually will often ask patients if they're willing and families to fill out an intake form that's very long. It's like more than 10 pages long, very in depth. And my secretary will tell them if they fill it out, I will spend an hour at least to review it before the actual visit so that we can really focus our time. And, you know, the information, if they fill it out, the information I get from that form is very helpful. Of course, I've already done a chart review, but it's very helpful for me to, you know, get information and save the time that we have, that 60-minute consultation time, to really focus on listening to their story. But my point is, even after all of that, well, I do it because it's good for the patient as well, because it makes them think about their history and why they're coming to see me and what they'd like me to help them with. But more than that, even after they fill out the form and I've reviewed it, when I actually get to meet with them, that's the time where I will still have them tell me their story. And so to me, every clinical interaction is a time for them to tell their story and for me to listen. And through their telling me their story, that gives me information on how best to direct them, you know, as far as, you know, making a plan, let's say. But it really has to do with their story. And you've mentioned very much so that, you know, if you say it a lot more eloquently, but if the patient's view is discordant with the physician's view, you're never going to get healing. And the physicians will call it non-compliance because they're saying you're just not, you know, you're not interested in doing what we think is best. So I think it's really important to hear the patient's story. And I mean, in some cases, you know, patients will cry, you know, it's just as they're telling the story, and that's therapeutic in itself. But, you know, hearing their story and what it is that's important to them, right? I mean, you say it a lot better than I do, but this, I feel that every day my clinical work is narrative medicine. Whether you call it that or not, that's what it is. That's the most effective clinical care.
Yeah. And what I've noticed, and maybe you have too, is that over the years it's gotten harder and harder to get people to tell their stories because they're used to walking, I think it's because they're used to walking into an office and getting 20 questions and and feeling like no one cares to hear the sort of step-by-step progression of what happened, you know, during the course of their illness. And I think William Osler would probably be really disappointed with us were he to return and see what we do in most of our consultations. I mean, do you find that also? Do you have to coach people to tell their stories?
Sometimes, but although like even this week I had someone say at the end of the form, if this in-depth you know, form is any indication of the actual visit, I'm really looking forward to it because I'm tired of not being heard, not being listened, and I want someone to support me in that way. So, you know, maybe it's because these are complicated cases and they've really felt dismissed by you know, maybe other clinicians, and they're still seeking. They know something is wrong. They feel something is wrong, and yet they feel like they don't have answers. I don't know. So, but
Yeah. Do you,
it is,
do you get many of the so-called medically unexplained symptoms people?
yes,
Mhm.
yes, exactly, exactly. There, it's exactly what it is. And people tell them it's in their head, or they're just, it's, you know, this kind of thing. Yeah.
Right, right. There was there's a fellow at Dalhousie University um, who created a program in emergency rooms in Nova
Hmm.
Scotia for intervening in a kind of narrative psychological way early on in their course for people with medically unexplained symptoms.
Hmm.
And so he mostly his students come into the room and they say, look, um, you're a complicated person. No one can figure out what's wrong with you. It's gonna take a lot of time. And in the meantime, what we can do is help you with lowering your stress because stress is bad for everything.
Hmm.
And lowering your stress is good for everything.
Yeah.
And and we might be able to help you feel better while they're figuring out what's wrong with you. Because that could take a really long time. And so apparently he has about 50% acceptance rate. Like people say, okay. And um, and it's been a very successful program because he saved the province so much money that they're giving him money to expand
Oh.
over Nova Scotia. And it's sort of a he's he uses Davin-Los's short-term psychoanalytic psychotherapy model. But it's really, I mean, that model is really about getting the story of of what's going on in your life and in your body at the same time that you're feeling these symptoms,
Hmm.
which is a kind of narrative medicine. It's a
Yeah.
kind of making meaning together. And I thought only in Canada could this happen because they have economic incentive to get people better. Can you, I don't know, can you see something like that happening in New York City? I
I
don't
don't
know.
know. Yeah.
Yeah, yeah. Well, it it's an interesting, I mean, we live in interesting times, which as you know is a Chinese curse. And you know, I try to convince the residents and the medical students that they are medicine,
Mhm.
that they don't have to do anything but listen.
Mhm.
And if they're just present in the room listening,
Mhm.
it's good medicine and people will get better and they don't have to know what they're doing.
Yeah.
Yeah, have you found the same thing?
Yeah. It takes the pressure off, right? Yeah.
Right, right. Yeah, I mean, because they come, I mean, you probably have this experience too as a faculty. They come to you and they say, well, I'm not doing anything for this person. I don't know why they keep coming back. And and I tell them, I say, people don't come back if you're not doing anything for them. The reason they keep coming back is because you are doing something for them. And they're like, well, what am I doing? I'm like, you're being present. You're
That's
witness.
consistent. Yeah. I'm sorry.
No, no, go
Yeah.
ahead.
No, I would say that's consistent with the motivational interviewing principles, like in lifestyle medicine, where they say, they tell the physician, quit your job, stop trying to solve the problem for the patient, tell them what to do. Instead, your job is to, sit alongside them, get on the bus with them, and, let them, you know, don't tell them what to do. Find out what it is that's motivating them. So it really is just listening.
Yeah,
I shouldn't say just listening, it is listening.
it is listening. Indeed, indeed. Well, we're getting close to the end. Uh, what did I not ask you that you really want to tell us?
Um, I I don't think I have anything else. I mean, I'd love to ask you something
Oh,
questions,
feel
but
free. I mean, yeah, go for it.
well, I've always wondered, what do you do in cases where people aren't open to telling stories or list changing stories, or some people just feel like they're not story people or they're resistant to it. Like, what do you do in those cases? Kind of like people who say they're not good with guided imagery, or, they can't imagine it. Is there, I was just curious.
Well, some people I can get purchase by talking about popular movies or
Mm,
TV shows that they like,
mm,
or with the adolescents video games that they play. But that's
mhm,
hard for me because I'm not of that generation of video games. But and telling sometimes telling stories, just say, well, could I just tell you a story, and if you don't like it, you can tell me that I'm stupid, or whatever. And sometimes I don't reach them.
mm,
Sometimes it just doesn't happen.
mm,
There's some questions that I use that often work, not always, but I ask people, if I wanted to understand your life, what movie would I watch?
mm.
When I was in New York City, I asked them what novel would I read, but in Maine, nobody reads novels. They only watch movies.
Oh, that's a good one. I like that.
Yeah. And then I'll say, well, is there a character in that movie, or is there another character that resembles you? That you know you really feel connected to. And that sometimes helps.
Mm,
Um, and another question that I sometimes ask is, what's your theme song?
mm.
And that sometimes helps.
I'm going to borrow all of those.
Well, when they work, and when they don't, they don't. And these days I'm seeing a lot of adolescents, and um, they're not big on telling their story to adults, but sometimes I can engage them with those questions,
Mhm,
and sometimes it's remarkable. It's almost like a projective test, the insight you can get from the characters to whom they identify.
mhm.
But it wouldn't come out in that sort of dry history that we all share, that comes in with them, or
Right.
or, or they wouldn't otherwise articulate it. And so that sometimes works. And I've had to allow myself not to be too disappointed when it doesn't work, when I can't get anything.
That's a wonderful
Sometimes.
experience.
But you know what I've learned is, if you can't get anything, you can always do acupuncture or osteopathy. I do both
I
of them.
agree.
Yeah.
Yeah, yeah, that helps.
And sometimes turning one particular needle, and something will let loose. Like
Mhm,
suddenly they'll start talking or crying or emoting or just spontaneously.
mhm,
So, so sometimes it's a surprise, I think.
mhm. I like that.
Yeah. For some years we did until COVID hit, we did an acupuncture anxiety group. And
Mm,
and so I did it with a colleague, and I would go around the room and put in the needles,
mm,
and while the colleague talked. And then when I was done, I would join in the talking or the guided imagery or whatever we were doing.
mhm,
And um, and that was really powerful too, because people, I think, I think there's something about being in the state of acupuncture that it's a non-ordinary state of consciousness to some degree.
Yeah.
And people would say things unexpectedly to
Hmm.
me from knowing them outside of the group. And
Hmm.
so I think these other modalities sometimes contribute to getting a story when you can't just sit in a chair with someone.
Hmm. That's interesting. I've done acupuncture with guided imagery in a one-on-one setting, but I've never considered doing that in a group setting. That's
Yeah, it was really good. And it totally requires two leaders
yeah,
because somebody has to lead the group while the other
yeah.
person goes around and puts in the needles. And we limited ourselves to um, feet, lower legs, arms, head, and ears. But you can pretty well cover most things with those points.
Yeah.
I always told the residents if you don't know what's wrong with the person and you only have four needles, liver three and large intestine four.
Yes. Four gates. You got it.
Exactly. And you'll do some good.
I did that one in the dental chair. Oh, no, this up.
Yeah, yeah.
Can't go on.
All right. Well, so this was fun. And
Yeah.
hopefully we'll run into each other again. And
Yes.
and I'm gonna stop the recording and say thank you for
Thank
coming
you.
on the podcast.
Thank you so much.